speaking throughout the morning, so the vocal cord energy has gone down. Okay, just to answer that question about regional anesthesia and laparoscopy. See, the main issue of ventilation during regional peritoneum is, pneumoperitoneum is, that if your diaphragmatic tone is maintained, then the problem is not there. The problem occurs as soon as you start paralyzing. So the moment you give a non-depolarizing muscle relaxant, the diaphragmatic tone is gone and the patient is not able to compensate at all and the atelectasis happens. So even in gynecological lower abdominal surgeries, because the diaphragmatic tone is maintained, atelectasis doesn't happen. The patient initially compensates with an increase in respiratory rates and then the body compensates and not much of a problem is seen. So it is basically the loss of tone of the muscle or that creates a problem, not otherwise. Okay, now coming to this topic of uptake, distribution and elimination. Let's start with what's the importance of this topic. The importance comes when we look at the minimal alveolar concentration. Now the minimal alveolar concentration as per definition means that it is the amount of the inhalational anesthetic in the alveolus, the partial pressure of an inhalational anesthetic, which will produce immobility to a noxious stimulus in 50% of the population. So it is 50% of the population, no movement to a noxious stimulus. That is what is MAC. Now if you consider one MAC, because it is in 50% population, it means it is PD50. That is, it's only for 50% of population. So that is good for LMA insertion. That amount of MAC is good for LMA insertion. But if you want 95% of your population not to respond to a noxious stimulus, then you would need a MAC of about 1.3. So your range of MAC would vary between 1 to 1.3 to have a good surgical anesthesia for any patient in 95% population. If you go up to about 1.5, then probably 99.9% patients would be properly anesthetized. So this is what MAC tells us, and it basically tells us about the anesthetic depth. So it tells us that at that depth of anesthesia, the patient would not respond to a noxious stimulus. That is what is MAC. It determines the anesthetic depth. Now different agents have different MAC. So when we look at different agents having different MAC because of their solubility or potency, so MAC is also used as a unit to compare different agents and their potency. So these are the two uses of MAC, to compare the potency of inhalational agents and as a marker of anesthetic depth. But must we remember that MAC is additive. So if you add two agents, it is additive and it can give you a higher value. Now what are the functional endpoints of MAC? You have seen different bars which are given in the books. One is MAC awake, the other is MAC, and the last one is MAC bar. So let's come to one by one. These are concentration response curves. At the x-axis is the percentage of inhalational agent. On the y-axis is the percentage of patients who would respond. So if you see these graphs, they are all almost vertical. When they are vertical, it means that the concentration of an inhalational agent here doesn't vary much when it has to produce complete anesthesia in almost 100% patients. It is almost vertical. Unlike MAC bar, where different concentrations of the inhalational agent would be used to produce a MAC bar or suppression of hemodynamic response in different category of patients. It is tilted towards the right. So what we are basically concerned is about this MAC, where we want to make sure that maximum number of our patients are anesthetized properly and are not aviated. So we want that 99.9% patients should be anesthetized properly, and that is the concentration we want to give to our patients. So towards the right would be the potency, this is the slope, and this is the maximum efficacy for all patients to be observed. So these are the two curves which define the MAC definition or the definition of anesthesia, which means that the patient should be properly anesthetized and the patient should be immobile to a noxious stimulus. So if you have achieved these two, if you have achieved amnesia and you have achieved immobility to a noxious stimulus, your patient is anesthetized. So the inhalational agents give you a property of properly anesthetizing a large number of population at a given concentration which is constant for majority of the population, because they are vertical slopes. I mean, they are vertical lines, they are not sloping towards the right. Right? So this is what is the anesthesia definition or MAC definition we were talking about, that patient should not respond to a noxious stimulus by movement, and patient should not recall or should have adequate amnesia that he had ever undergone surgery. So we have to concentrate on this, and no other agent can give you such precise concentrations of making your patient anesthetized other than the inhalation agents. To overcome the hemodynamic responses, you have to combine your inhalational agents with various other agents, like you use beta blockers to suppress the hemodynamic response, you use nerve blocks, you use epidurals, you use opioids. So all those agents will help you to get a MAC bar, provided you maintain your volatile concentration in this. So rest fentanyl, beta blockers, local blocks are there to suppress MAC bar responses. They are different than anesthesia. Anesthesia is this, just these two bars, right? So just remember this, that these two are different entities. So once you have the fractional concentration of about 2% for sevoflurane, the end-tidal concentrations, almost 99% of your patients would be properly anesthetized. But if they still have an autonomic response, then you will have to supplement sevoflurane with fentanyl, with other drugs. Those are supplementary, and that is called as balanced anesthesia. So the population variability is extremely less when you use volatile agents. So the concentration is almost fixed for majority of the patient, and variability is only just about 10 to 15%. Now with this background that what the inhalation anesthesia does is to properly anesthetize the patient, let us talk about the uptake of inhalation agents. Now uptake and equilibration are the 2 points we need to consider together. How does the inhalation agents go inside the lung? You need a set concentration, a vaporizer to deliver it. You need alveolar ventilation to take the vapor inside into the alveolus. And from the alveolus, these vapor has to go across into the blood. That means that the vapor is now going from a gaseous medium to a liquid medium. When it transgresses from one medium to another, there will be a coefficient. So here it is blood gas coefficient. So for liquid it is blood, and gas is what is in the alveolus. So we need a coefficient when a vapor goes from one phase of matter to another. So from here, from the alveolus, it is going into the blood. That's why you have blood gas coefficient or blood gas solubility. Now from the blood, these vapors have to be delivered to the ultimate effect organ, and that is by means of cardiac output. It goes to the brain. So when it reaches the brain, again it has to go from blood into the brain. So that is what will again have a solubility. because it is going from one phase of matter to another, so you have tissue gas solubility coefficient there. So these two coefficients, just remember the purpose is that the vapor goes from one phase of matter into another, therefore you will have a coefficient. Now for this vapor to reflect the same concentration in the brain as in the alveolus, there has to be equilibration which has been achieved, right, in the alveolus, in the blood and in the brain. Then only 1 Mach in brain would represent 1 Mach in the alveolus. And what does we mean by this equilibration? It means that the partial pressure, remember partial pressure of the volatile agent is equilibrated across these two areas and across blood and tissue. It's not the concentration. So the concentration at which partial pressures are equilibrated is what is defined as a steady state. That's the steady state of anesthesia. And it takes time. It doesn't happen immediately. So whenever you start your inhalational agent delivery, it will take about 12 to 15 minutes for this steady state to be achieved when you can say that your patient is properly anesthetized. So catch my point, you may deliver whatever concentrations you are giving, but ultimately it's the partial pressure across blood and alveolus, blood and tissue, which needs to be equilibrated so that you have 1 Mach representing 1 Mach here in the brain. Now what are the factors which influence your alveolar concentration? So when we look at alveolar concentration, you see that there are factors which can alter the inhaled portion or the inhaled tension of the agent. And secondly, it can be factors that can affect the rise in alveolar tension and the uptake of blood. So there are 3 factors which are responsible. Factors which affect the inhaled tension, factors which affect the rise in alveolar tension at this point, and the uptake of blood. So whatever is, we'll deal one by one in about these factors now. So first let's consider the factors affecting the inhaled tension. Now for the inhaled tension, the factors which can modify are, first is the fresh gas flow which you are going to give and what inspired concentration you are going to set onto the vaporizer. So that's one factor which will affect your inhaled concentration. So if you give a higher concentration, the inhaled concentration is going to be more. Now these vapors are going to be given through an interface between the lung and the vaporizer, and that's the circuit. And all of our circuits are made up of different material, specifically rubber. So you have rubber gas solubility. Some of the vapors can actually be soluble in rubber. So you may lose the concentration which you have set here. So the concentration, if you have set at 1, in the circuit it may come down to 0.8 or 0.9 depending upon the rubber gas solubility of the agent. The second one is the type of circuit. If you use a larger volume of circuit versus a smaller volume of circuit, that will again take time to equilibrate. Right? For a closed circuit, it will take time. And the point at which you are delivering the fresh gas flow. If you are giving it here or just near to the patient, again you will be bypassing most of it and the rubber gas solubility may be much less in those areas. So the circuit volume, the entry point of fresh gas flow, the rubber gas solubility and the set inspired concentration are the ones which will govern the inspired concentration or the inhaled concentration of an inhalation agent. Now we are setting something like a concentration on the dial. And I told you that all agents are actually represented as partial pressures. So when you have to convert your concentration into partial pressure, you have to put Dalton's law into force. So the partial pressure of the gas is the fractional inspired concentration into the atmospheric pressure. So for oxygen, if it is 21%, it will be 21 upon 100 into 760, and you will get what? And you will get the partial pressure as 157 millimeters of mercury. Right? So that is how the concentration is transformed into partial pressures, and these are the partial pressures which play a role inside the body, not the concentrations anymore. Now next we come to the factors which affect the alveolar tension. So we have talked about the inhaled tension. Now let's talk about the alveolar tension. What factors can play a role? So the factors which play a role in the rise in alveolar tension are two, which are described in books. That is the concentration effect and the alveolar ventilation. And these are nothing but the molecular movements which occur across the alveolo-capillary membrane. One is into the blood, the other is into the alveoli. So one which is occurring into the blood is the concentration effect, and which is occurring into the alveoli is the second gas. So we deal one by one what is concentration effect and what is second gas effect. So look at this concentration effect. Now when you are having an alveolar ventilation, you have nitrogen, you have nitrous oxide, you have oxygen, and you have some amount of sevoflurane or halothane or elimination vapor. So whenever you are finding that the alveolar ventilation occurs, you will find that nitrous oxide is 20 times more soluble, right, than nitrogen. So nitrous oxide, when you give, completely suddenly goes inside the blood. So what happens? The alveoli which was expanded because of these molecules of nitrous oxide has lost its volume. So the alveolus shrinks in size. And when it shrinks in size, that is what would be called as a concentration gradient. Because the amount of gas which is remaining in the alveolus has suddenly come down because nitrous oxide has diffused into the blood. So the alveoli will now regain its volume by augmented ventilation. So it starts augmenting the ventilation, drawing in more of nitrous oxide and fresh gas flow to compensate the loss of volume. So that is what is called a second gas effect. Now to translate these two, concentration effect and second gas effect, let us consider some of the figures. How does it figure out? Now this is what you normally give. This is your inhaled agent. You are giving about 19% of oxygen and you are given 80% of nitrous oxide. The total volume is 100%. Now when 50% of the nitrous oxide is taken up, then what happens? The alveolar size comes down and you find that the nitrous oxide percentage is reduced to 40%. Oxygen is 19%, but the second gas on the vapor is still 1%. So what does it translate to? How much loss has occurred? So 40 by 60 into 100, you will find this has come up to 67.7%, the concentration of nitrous oxide here, and the oxygen has gone up to 31%. Right? So although this nitrous oxide has been lost by this much amount of percentage, but there is a net gain in oxygen and there is a net gain in the inhaled concentration also because of the volume which has contracted of the alveoli, because their concentration has not been affected. So the total concentration in that contracted volume of the alveoli has made the inhalational agent go up in concentration and the oxygen concentration go up. Right? This is called as a concentration. Now let's see the second gas. Now the patient takes another volume of ventilation. He takes an inspiration. So this time what he will take is, he will take the whole of this volume, that is 80% nitrous oxide, 19% oxygen and 1% of the gas. So next tidal volume the patient is going to inspire this. So what happens to this? He is trying to compensate for the 40% volume which has been lost. So you will see that these gases compensate for the loss which has occurred here. So he will have another 7.6% oxygen coming here, 32% of nitrous oxide coming here, and another 0.4% of the second gas or the inhalation agent coming here. So the volume would be calculated by 80 by 100 into 40 is what you will be getting at this particular point. So this it becomes as 32%. So that is how the second gas effect takes place. So the second gas effect is the amount of volume of 40% which is compensated by the next inspiration containing the same mixture of air, and the final concentration is 40 plus 32 is about 72%. Right? So this is what is called a second gas effect, and to an extent you will find that your inhalational agent has, the concentration has finally gone up in a same volume which was existing here. It has gone up to almost 1.4%. Correct? Just because the nitrous oxide has diffused across. Correct? So this is what is concentration effect, and this is what is second gas effect. Now let's consider the effect of ventilation. So that's the second part. So we have already dealt with concentration effect. Let's talk about effect of ventilation. Now consider a hypothetical situation where the patient is going to breathe 100% nitrous oxide. Right? Because nitrous oxide we have taken because nitrous oxide is highly insoluble in blood. Right? That is what it is. So when the patient takes the first breath, 500 into the total volume, that is 2.5 liters into 100, you will find that when you give 100% oxygen, at the end of first breath, the alveolar concentration of nitrous oxide would have reached 20%. Correct? Right? So this is your total volume, and this is the rate at which the ventilation is going in. So 2.5 liters is your dead space containing the tidal volume and the FRC. Then 500 of the tidal volume divided by the total volume of 2.5 liters into 100, you will get the nitrous oxide concentration of only 20% in the first breath if you are giving 100% through the flow meter. What happens with the second breath? With the second breath, you will find that the concentration of nitrous oxide has gone up to 36%. It has not gone to 40%. So there is an exponential rise. It is not just doubling up. And that is what I was telling you, that 40% has been lost there. Right? So this is how it is compensated here by only a rise of about 16% in the second breath. Now in one breath, in 1 minute, for a respiratory rate of 10 if you see, the alveolar concentration of nitrous oxide would be 86% of the said 100%. So you would not have achieved still 100% here at the end of 1 minute. So it has taken 1 minute for what you have set 100% here to achieve 86% in the alveolus. Okay? Now this is what is an exponential rise, and to achieve 96% rise in the alveolus to the set of 100%, it takes about 6 time constants. So we are coming to a terminology called time constants. What are these time constants? So the time constants are basically 3 of them. If you consider a single compartment, if the compartment has to reach 63% of the set concentration, that is one time constant. So the time in which the compartment would achieve 63% of the concentration of what is being delivered would be one time constant. That is what we say as 1. And the time for which it takes 86% concentration to develop to the set 100%, then it is 2 time constant. And when it takes 95% concentration to happen as against the 100% which is set, it is called 3 time constants. Right? So these are the time constants which we need to consider. And these time constants play quite a lot of role in scientific understanding of how you govern your flow rates and your inhalation concentrations. So the time constant is nothing but volume by flow. The volume by the flow which you are giving. So you have 2 volumes here. One is the circuit, the other is the lung. And the flows are, the volume by flow will be the circuit capacity divided by the fresh gas flow, and in the lungs it will be the function residual capacity divided by the alveolar ventilation. Right? Is it clear? So these are two compartments which we are considering separately. Now what we are worried about or what we are concerned about is the time constant in the brain. Finally, we want to know how much time will it take for the alveolar concentration to match the brain concentration, right? So for that, for tissues, apart from volume and flow, you need also to consider solubility of the agent. So if you multiply the solubility into the time constant, you will know what would be the time constant for the brain. So to understand, I'll just give you an example here. Now look at the circuit. The corrugated hose has a capacity of 3 liters. The reservoir bag has 2 liter capacity. Circle absorber has 2 liter capacity. So the total volume, circuit volume is 7 liters. Right? Now the FRC of the patient is 2 liters. So the total volume is 9. So total volume is 9 liters. And if you set a fresh gas flow of 6 liters per minute, then your time constant would be 1.5 minutes. That is, in 1.5 minutes, you will be able to achieve 63% concentration of the agent in the lungs. Right? So that is what it will mean. But if you want to achieve 86% of the concentration, then it has to be 2 time constants. That is, it will be 3 minutes. And if it has to be 95%, then it has to be 4.5 minutes. So that is how the time constant tells you how your circuit or the FRC would be equilibrated to the set concentration on the dial. How much time will it take? So this is what is meant by time constants, and we must try to understand this. So now if your circuit volume is 1 liter and your FRC is 2 liters, suppose we take a smaller circuit, then what happens to your time constant? Time constant becomes 0.5. So it becomes easy to prime the circuit first, a smaller volume circuit, where the circuit concentration can match the inspired concentration at an earlier time. So I am asking you a question now. Suppose I want to prime the circuit. How much time will it take to achieve 95% concentration in a 6 liter circuit with 6 liters per minute of 100% oxygen?
3 minutes.
3 minutes. Correct? So one time constant is 1 minute, which will give you 63% concentration. If you take 2 minutes, it will be 86%. And if you want to have 95% concentration, you will require 3 minutes. So you will have to have 3 minutes at least to prime the circuit with 100% oxygen to get an inspired concentration of 95% to the patient, if you only consider oxygen in the circuit. If you want to prime your circuit with only oxygen, this is the time it will take. Correct? Right? Because that thing is filled up by air. So everything has to be washed off slowly. It will take some time, and it will take that much time, 3 minutes, to have 95%, the circuit giving you 95% concentration to the patient. Before that, it will be much less. Now let's come to the brain. What about the concentration in the brain? What is the time constant? Again, we relate to the same formula, the tissue capacity or volume and the blood flow to the brain. So let's take about 100 grams. So what is the time constant there? So if you look at the blood-brain solubility of these patients, these are the solubilities which have been given and determined, and all the agents have this. So it takes about 3 time constants for this to reach this value, right? So how does it take that much time? Because each gram of grey matter gets about 1 ml of blood, and brain time constant is equal to solubility of the agent, because it is so highly profused. So it becomes easy to analyze. So whatever is the solubility of the agent into 3 would give you the time constant in which you will be able to achieve the brain time constant. So all you need to know is, to get 3 times the time constant, you multiply all of them by 3, and these are the 3 time constants you will get. That means 95% equilibration will occur for these agents in this much amount of time. So for sevoflurane, it may just take about 5.1 minutes to achieve 95% concentration. Used in real time in about 22 seconds. And that's the time you take to induce the patient with control. Is it clear? Are you seeing it? This is real time what is happening. So what the vital capacity induction has done is that within 22 seconds, I am able to have a smoother and a faster induction with an inhalational agent equivalent to an intravenous agent. There is total hemodynamic stability. Right? It doesn't cause that kind of a fall in hemodynamics as the intravenous agents can cause. And it can safely be used in day care because it's easily washed out. Right? So these are the advantages. But when you start doing this, there is a lot of science behind how you do it. So you need to know your time constant for your sevoflurane. When you set it at 8% with a 6-liter flow, how much time will it take for the circuit to be fully primed with that amount of vapor? So that much amount of time you will allow the circuit to be primed with the patient end closed. So I'll just show you the video again. How do we do this? I want to achieve an end-tidal anesthetic concentration of 7%. So what I have done is I have closed the patient end of this circuit. This is totally closed. Right? I have put the ETCO2 monitoring line here. It also monitors the anesthesia agent concentration, inspired and expired. The expiratory valve is open. Remember, it's a semi-closed circuit, so you have to open up the expiratory valve. So this is how the patient end is occluded, and this is a lympho circuit with an HME which we are using. And this expiratory APL valve is open. I have set a flow rate here, if you look, is about 6 liters. Right? So this is a 6-liter flow rate which I have set, and sevoflurane concentration at 8%. And what do I get? After about 4 to 5 minutes, I will find my end tidal and my inspired concentration equilibrated at 7.2. I do not get 8% there, I get 95% which is achieved. There may be some amount of loss which is spilling over from the APL valve which has to be compensated, so you will never reach 8%. At the maximum you will be able to achieve about 7%. So this tells me that my circuit is now primed. So the moment I keep the circuit over the patient and put on the fresh gas, so when we put the circuit over the patient, what do? We switch off the fresh gas flow. So that all that concentration which you have built up in the circuit is not lost to the atmosphere. You don't wash it off. Because the volume was about 2 liters only, in which this circuit has been primed. The moment you open up with the fresh gas flow, the volume is the room's volume. So everything is lost. So your patient will never be induced by a vital capacity. So you prime the circuit up with a sevoflurane concentration. So the circuit is giving the same concentration as what you have set as an inspired concentration. And the moment you put the mask onto the patient, then you switch on the fresh gas flow and ask the patient to take a deep breath. That has to be simultaneous. So as soon as the patient takes a deep vital capacity breath, once and then twice, patient is induced. That's all it needs. So there is a lot of science behind understanding time constants and how much time you will do. And this effect is achieved by something called as an overpressure effect. We'll come to that and in a little while. Now let's understand the uptake by the blood. Now the uptake of the inhalational agent is governed by the Lowe's formula. What does it tell us? It tells us about F, it tells us about MAC. It tells us about the blood gas solubility, it tells us about the cardiac output, and it tells us about the time. What is this F into MAC? Remember, there is a venous return which is always occurring to the alveolus. So the gradient between the concentration or the partial pressure in the venous blood to the alveolus determines how much of it will come into the into the blood again. Right? So it's the return blood which is coming back, which will tell us how much it is going to allow the vapors to come. So if it is highly saturated, the venous blood, there will be less amount of uptake from the alveoli. But if the venous blood has less amount of partial pressure, more of it will go into the, so it's against a gradient. That's how the uptake would depend upon the alveolus. So one is the gradient. So initial effect or the rise is because of ventilation or the alveolar washing, and this knee is produced because of cardiac output. Because now it has not been able to reach 1. Before it can reach 1, it has plateaued because some of it is going into the blood, right? And that is why it is constantly being removed from the blood. That is why you get this knee, and then you get a plateau. Now this plateau, if you see, is upsloping. It is not absolutely straight. Now it is straight, it is upsloping because of venous return. So if the venous return is containing the agent, then this plateau will be slowly upsloping. But if there was no venous return, then it would be straight slope. There will be a constant uptake. But you see that the venous return decreases the uptake and slowly it is moving towards 1 because their returning blood is getting saturated by your inhalational agent, which is being supplied to the muscle, to the other organs as well. Right? So there are 3 things which you are producing. One is your effect of ventilation, which produces an immediate rise, and then this doesn't continue to rise here because the blood takes away the inhalational agent, and that is the effect of cardiac output. Then you get a plateau which is upsloping because there is venous return and some amount of vapors are returning back as the tissues are getting saturated with inhalational vapors. Now these are the FAFI curves or the alveolar curves which we talk about when we consider their blood gas solubility. Right? You will see that the halothane has a knee much less than 0.5. Isoflurane is also below that, but the best part is the desflurane and the sevoflurane, which are much higher, which are about 0.6 and 0.7. So these are the height of the curves which determine the blood gas solubility. So more soluble the agent is, it will never reach the value of 1 which is being set. Right? Because all of it gets wasted in the blood, it gets dissolved. So whatever gets soluble in blood is wasted vapor because it doesn't produce any tension. It doesn't have any partial pressure. Only the insoluble part would produce a partial pressure. So the insolubility of the agent as it goes up, you will find the alveolar curves are higher up. So it gives you the blood gas coefficient of each inhalational agent. So this is these are the FAFIs of different agents, and as you see that it is quite, these one are the 2 ones which are quite close to each other. Now what is this blood gas solubility? Now as I told you, blood gas solubility means that the concentration of the vapor in the blood to the concentration of the vapor in the gas. So what is in the gas as against the concentration in the blood. So if 50% of the vapors dissolve in blood, the solubility is 0.5. If only 1 portion gets dissolved in blood, the solubility, the vapor is more or less insoluble. And if all of them except 1 get dissolved in blood, then it is highly soluble in blood because that's all wasted. What's the clinical implication of this? So isoflurane, if we say, has a blood gas solubility of 1.36. What does it mean? It means that the concentration of isoflurane in blood is 1.36 times more than in the alveoli when the partial pressures are equilibrated. That sentence is not given in books properly. So please remember this. This means when the concentration of isoflurane molecules in the blood is 1.36 times more than what is in the alveoli, At that point, the partial pressure of isoflurane in the alveolus and the blood are equilibrated, are equal. Right? So it has to be more of isoflurane has to go into the blood. The concentration may be higher. So at that but higher concentration in the blood will equilibrate to the concentration in the alveoli, because at that particular concentrations the partial pressures are now equal. So the equilibration of partial pressures is the most important thing when we talk about blood gas solubility. So the alveolar deficit at the plateau end, if you look at, is what it sees, is what we get it initially. Initially you will find that the alveolar deficits are quite high. But as time progresses, the alveolar deficit remains almost constant. For desflurane it will be 12%, for CO it is 17%. So what are we looking at? Initially we looked at the FA-FI ratios here. But when we look at the ratios at this point, it makes more sense to us. Because we want to know the alveolar tension which is controlled at a certain plateau height. If you want to determine what is the alveolar tension which controls this plateau height, then it is better to invert it. It is good to see Fi versus Fa ratio rather than Fa by Fi ratio. So if you look at Fi by Fa ratio, you will know what is the alveolar tension which will control the plateau height. And this is the genesis of overpressure ratios or overpressure. Because that is what is the desired alveolar tension you want to achieve as fast as possible. How do we determine what is the overpressure ratios and MAC? Now look at the inhalational agents. These are the overpressure ratios. But how did they get this number? How did you know that sevoflurane 3.8% would produce an overpressure effect? It is by again these alveolar curves. The point at which you get the plateau which is happening is 0.54, right? And the Fi ratio into MAC will give you the overpressure effect ratio. So it is 0.54 into the MAC value, which is giving you the 3.8 concentration of sevoflurane. So Fi is 1, which you want to achieve, but you have achieved 0.54 or 0.55. MAC is about 2.1 for CO, so the overpressure effect ratio should be 3.8. So that's the amount of sevoflurane you will have to give to the patient to maintain a plateau. And that is the reason we tell you always that keep your sevoflurane concentrations at 3.5% at least, the inspired ones, produce an overpressure effect. So the overpressure effect is nothing by giving a larger dose to the vaporizer and flooding the lungs so that it can achieve the brain concentration at an earlier time. So it is analogous to an intravenous bolus. Higher vaporizer settings are used with higher gas flows to achieve higher alveolar concentrations, so that the inspired concentration is always higher than the brain concentration, so that the equilibration can achieve at a faster rate. Now what's the effect of ventilation? Of course it's very simple to understand that if you have a ventilation which is at a higher ventilation rate, then the Fa-Fi ratios are achieved much earlier. But it doesn't make much difference when the gas is insoluble like in nitrous oxide. But if it is a soluble agent, then it makes a lot of difference. So if the patient can have a higher alveolar ventilation, then you will be able to achieve the anesthetic depth at a faster rate than when you give lower ventilation to these patients. Now what about the distribution? We all know it follows the Mappleson's water analog. So from the mouth you give the patient, through the alveolar ventilation it goes into the lungs, and from the lungs through the cardiac output it is given to the viscera, to the muscle and to the fat. See the viscera. Viscera which are highly perfused get equilibrated early. The ones which are intermediately perfused and low perfused like fat get equilibrated at a very late stage. So that is the circulation which will lead to equilibration in different areas. Now, for a highly soluble anesthetic, what we need is that for equilibration, the larger reservoir and larger quantity of anesthetic agent, and it takes a longer time. So the reservoir becomes larger for a soluble agent because most of it is getting vented into the blood because it is soluble. But for a low solubility agent, the reservoir is much small because it is insoluble. So it doesn't actually diffuse into the tissues like muscle and fat as much. So the reservoir becomes small, and the small quantity of anesthetic is required, and in a lesser time you can achieve that equilibration. That is how it is achieved for nitrous oxide. So just see this this graph which I wanted to show you. This is the circuit concentration of the sevoflurane. This is the alveolar concentration. This is the brain concentration. We started with an inspired concentration of 6% sevoflurane with a fresh gas flow of 6 liters, which is totally constant. So as soon as we achieve, this is the MAC. This gray line is MAC 1. That is what we want to achieve. So look at this. With 6% in about 5 minutes, we have been able to achieve alveolar concentration which is much higher than what is in the brain. Right? So at 5 minutes only the brain gets close to the MAC value. Right? So it has taken about 2.5 minutes more from the alveolus to the brain to reach the same MAC value. Right? And then it takes another about 2 minutes more. It takes another 2 minutes more for the brain, the alveolus and the circuit concentration to come to a similar level at this particular point. That is at MAC level. So when it falls here and when you decrease your concentration now to 2.5% with the same fresh gas flow, you will achieve equilibration in about 7 minutes. So it takes about 7 minutes, 5 to 7 minutes for anesthetic depth to be achieved when you use sevoflurane as an induction and a maintenance agent. What's the effect of cardiac output? Now this is a little interesting. You'll find that the soluble agents, if the cardiac output is high, the FA-FI falls down. But if the cardiac output is low, then the FA-FI increases. Right? How does this happen? Now if the ventilation is normal, you're giving the vapors to the anesthesia circuit. And that relates to the pulmonary blood flow, whatever is happening to the cardiac output. So if the cardiac output decreases, that means it is the passenger train which is going. So it has more time for it to get equilibrated. So more people can go inside the train if it is empty. Right? But if the transit time is short, then less amount of time is available for the vapors to go in. So when the cardiac output falls, the alveolar concentration rises up and the uptake is decreased. Right? And that is why there will be profound side effects if you keep the same concentration at that particular time. And if the cardiac output increases, then you will find that the FA-FI would actually come down. Right? So this is what happens. Now let's translate the same into the Gassman equation. Our ventilation is the same, 4 liters per minute. Now this is 5 liters of cardiac output. So at 5 liters of cardiac output, you will find that the alveolar tension is almost at this particular point. And as soon as the cardiac output falls to 2 liters, that means there is a blood loss, you find that the alveolar tension starts going up. The tension of the alveolar of the agent in the blood also goes up to much higher. So it can produce lot of side effects, hypotension and all. Because the cardiac output has fallen, but the concentration of which we are giving sevoflurane is the same, at the same rate. Now once the cardiac output is retained to 5 liters, you will find that the alveolar concentration again drops back to MAC value, but the brain takes a little while for it to come back to the same value. As soon as the cardiac output increases to 8 liters, the alveolar concentration falls below MAC, and so does the brain level concentration follows if you keep the same level of sevoflurane going. So with a decrease in cardiac output, the levels of inhalational agent is going to go up into the blood, it is going to go across MAC and also at the alveolus, so you need to decrease your agents at that particular time to match to the cardiac output. And when the cardiac output is restored, make sure you return back your inhalational agent back to what you had started with, so that the patient doesn't become light in anesthesia. What about the alveolar venous anesthesia gradient which we had talked about? So this is your alveolar gradient. It has to go into the arterial blood. So when it is taken up by the pulmonary blood flow, it goes into the left heart. From there it goes into the aorta, and it goes into all the organs. Now the venous return comes after the tissue has taken up some of the agent. So what it comes into the right heart, goes into the circulation here, and then it depends upon the gradient between the alveolus concentration and the venous concentration, and that determines how much of the alveolus will empty into the pulmonary circulation later. So if it is already getting saturated, that is the tissue uptake is coming down, this uptake also would reduce. But if the tissue uptake is still very high, this uptake would be high. So if there is an increase in the concentration in the returning blood into the pulmonary circulation, this the difference would come down and the uptake would fall. Now we talked about the shunt in the morning. If there is an increase in shunt, you know that shunt means that the blood is being shunted out from the lungs. It is not going to the lungs. So inhalational agent is being delivered to the lung, and if the blood is not reaching the lungs at all, or reduced amount of blood is reaching the lungs, then there is going to be a decrease in tension of the inhalational agent in the arterial blood, and because there is increased gradient, you will find that there is significance for insoluble agent, there will be slow in induction process. That is because the lung is being bypassed, which is a channel where the volatile agents are being delivered. What about your tissue uptake? It is all related to what we have talked. So instead of blood gas partition coefficient, it is the tissue blood gas blood partition coefficient. Instead of cardiac output, it would be the tissue blood flow which will determine the uptake, and instead of alveolar venous, it would be the arterial tissue with pressure difference which will determine the uptake of the tissue. So the tissue blood flow, if there is a high blood flow, there is a faster delivery of the anesthetic like to the brain, and there is rapid equilibration of the tension. So the total amount of gas which is dissolved again depends upon the volume and the solubility agent. That is what we discussed right in the beginning, the time constant. So if you apply the time constant area here about the flow divided by the capacity into solubility, you get the tissue blood flow which we are talking about. Elimination is an exponential process, and what happens is initially it comes from the vessel-rich group, and slowly it is eliminated from muscle and fat. So it's an exponential process which takes time. If it is a soluble agent, then you know that the solubility would be greater for muscles, for vessel-rich group and for fat, and it will take a longer time for the patient to come out from these agents to recover back. However, if it is something which is insoluble, which only remains in the blood and is not much soluble, these volumes are contracted, and you will find that the patient would come out extremely fast. For nitrous oxide, it just takes 2 minutes for the patient to completely recover from nitrous oxide. That's all. So you just have to stop at the end. We know about the diffusion hypoxia, and you remember that about 90 to 95% of nitrous oxide is eliminated after it is stopped within 2 minutes. So at the end of surgery, it is better to stop. Now this is something interesting again relating to gas plan about recovery. Now this is a surgery which has lasted for 2 hours. So this is the time when these surgeries, for the time which we have given an inhalational agent. These are different inhalational agents which have been stimulated. Red is for halothane, yellow is for enflurane, isoflurane is violet, sevoflurane is black, and desflurane is blue. So we are trying to see that if you switch off the agent at 2 hours, that is at this point, how much time would it require for the patient to recover? And if we continue with the same fresh gas flow of 1 liter per minute, which we have given for 2 hours. So the target point is 0.3 Mach. 0.3 to 0.2 Mach is the Mach awake when the patient should wake up. So how much time does it take for the concentrations to fall to this 0.2 Mach? If you look at these things, you will find that for the desflurane, it may just take about 16 minutes. For sevo, it may take about 17 minutes. For isoflurane, it may take 22 minutes. But for enflurane and halothane, it may take about 45 minutes. After you have stopped the agent and you continue to give 1 liter of fresh gas flow at the end of 2 hours. So can we hasten the recovery? Right? Is there a possibility of hastening it? So what we do is, let's increase the fresh gas flow to 6 liters. So after the surgery or when the surgery is getting over, let us increase from 1 liter, which we were giving initially, let us increase the fresh gas flow to 6 liters. Now what happens to the recovery profile? Now if you look at the same recovery profile, within 4 minutes the patient will wake up after desflurane, within 7 minutes from sevoflurane, within 10 minutes with isoflurane, 13 minutes from enflurane, and about 18 minutes after halothane. So you can actually titrate your recovery from the patient. It doesn't depend upon the solubility always. It also depends upon the common sense. So if you have halothane, switch it off early. You can increase your flow rates and you'll have a similar recovery to what you will have with sevoflurane. Or at times you can open up the APL valve, just give an oxygen flush of 60 liters, let everything be washed out. So once everything is washed off, there will be a increased concentration gradient across the alveolus, right? And the circuit, and the alveolar washoff would be much higher. But remember, when you do all these things, there is a possibility that some of the agent is still being mobilized from different parts of the body like muscle and fat. So initially the patient may wake up. But when you shift the patient to recovery, the patient may again go into a slumber because that amount of agent which you have washed off from the alveoli, right, has got reaccumulated in the alveoli with the stores being mobilized from muscle, from fat, and from the other organs. So you have created a gradient initially for 4 or 5 minutes, but slowly again the alveolar concentration and build up, and the patient has become drowsy. That's the reason when the surgeries go for a prolonged period, it is better to ventilate these patients post-operatively for some time so that you have a completely awake patient at the end of surgery when you extubate. So keep these things in mind. So just to recollect whatever I have said, the FI or the factors affecting FI are again the fresh gas flow, the circuit capacity, the fractional inspired concentration, and whatever you have given there, and the alveolar ventilation. The factors affecting the increase in alveolar tension is the concentration effect and the alveolar ventilation which we talked about, the second gas effect which we talked about. The uptake from the blood is again dependent upon blood gas solubility and cardiac output. And then when we talk about tissue uptake in the brain, it is similar to tissue gas solubility and tissue blood flow. And when you have to see the uptake again, you will find that elimination would occur against the concentration gradient. So as the concentration gradient is created between the alveolus and the venous, the uptake would reduce and the elimination would be hastened by increasing your fresh gas flows towards the end. Thank you very much.
So in concentration effect, it has been said that nitrous is 20 times more soluble in blood. But as we know that nitrous is less soluble, so there is more uptake of nitrous in comparison to others. There is
In relation to nitrogen. In relation to nitrogen, nitrous oxide is 20 times more soluble. The reason is that nitrogen your airway is expanded. But when you replace that with nitrous oxide, right? Nitrogen is replaced by nitrous oxide. Then that is 20 times more. That is why the alveolus loses its total volume.
So, but we are giving the inhalation agent along with that. But in comparison to that, nitrous gets absorbed more rapidly.
See, the nitrous is absorbed, right? The nitrous has gone into the blood, which is what is gone solid, what is lost, right? And when the volume of the alveolus comes down, in the lesser volume, the concentration of the inhalation agent, which was already present, goes up. That's the concentration effect, right? Now the second gas effect is when the fresh gas flow of the same composition of nitrous, oxygen and inhalation agent is delivered. That 40% is, which has been lost, right, is replaced by the same mixture. That leads to a rise in your inhalation agent from 1% to 1.4%. So that's the second gas effect which has happened with the nitrous has helped you to increase your concentration to 1.6, 1.4%. Which would not have happened otherwise if only oxygen was used. So that's the second gas effect of nitrous oxide, which has helped you to increase the concentration of your inhalation agent in a similar volume of alveolus which was existing before. And it is a consequent of concentration effect plus augmented ventilation which happens next time to compensate for the loss of oxygen. Fentanyl on sevoflurane requirements for somatic and sympathetic responses to surgical incision. Right? Let's see the effect of MAC. Now what you see here is the blood concentration of fentanyl. 0 means there is no opioid which is given to the patient. That means the blood concentration of fentanyl is 0. The normal concentrations of fentanyl in the blood which we require is about 2 to 4 nanogram per ml. And these concentrations are achieved by 1.5 microgram per kg of fentanyl. Is it clear? When you don't give any fentanyl, this is MAC 95, the dotted line, right? You would require a sevoflurane concentration of about 2.5. Right? About 2.5 for MAC 95 for no movement to occur. So for no movement to occur, about 2.5 to 3, that is what you will require when you give no fentanyl. Right? So that is what you would require if no movement should occur to a surgical stimulus when only sevoflurane is used. But when you start giving fentanyl, 2 to 4 nanogram per ml, you will find from here it has dropped down to almost 1.5, that's the maximum, at 4. So it has dropped down to 1.5, that is what majority, 1.5 to 1, that is in between where maximum patients have come. So your MAC has reduced by fentanyl. But giving a lot of fentanyl, let's say 10 nanograms per ml, you have given 5 micrograms, 10 micrograms per ml, has it allowed the graph to come down to 0? No. The graph is plateaued. That means you still require a volatile agent even if you have loaded the patient with fentanyl. So there is an effect on MAC bar. That is what I was telling you. Anesthesia is produced by inhalational agents. Autonomic reflexes are suppressed by fentanyl. It will also help you to reduce the MAC. It will also help you to reduce the autonomic responses, but it will not produce anesthesia. For anesthesia, you will have to give a volatile agent. So by giving about 2 microgram per kg of fentanyl, there is a drastic fall in MAC bar. After that, even if you give 4 microgram per ml, the change is very minimal. So there is a ceiling effect. There is no point in giving more than that. So 1.5 macrograms per kg is the maximum which you should aim for, which will help you reduce the MAC and also help you decrease the autonomic responses. Beyond that, it is not going to help. In fact, there are reports that there are opioid-induced hyperalgesias which occur even with remifentanil. So be careful when you use narcotics. This is what you should use. And if you ask me how I use it, clinically, I was talking to Aruna in the morning also. The peak effect of fentanyl comes in about 3 minutes or 5 minutes. How many of you wait for 5 minutes after giving fentanyl before you start your induction? Raise your hands.
3 minutes.
2 to 3? How many of you immediately give an induction agent after fentanyl? Lot of you. So there has to be a time which you should allow for the fentanyl to act to make a judgment onto the patient what has happened. Effect of action of opioids on systems are that first it produces analgesia. That's the first effect. After you increase the dose, it produces sedation. The third effect, after you increase the dose further, it produces respiratory depression. So if your patient gets sedated with an opioid, and if you allot sufficient time, that is the dose which you need to give. Don't equate it to the Western population. They may require 5 micrograms, but our Indian population doesn't require more than 0.5 micrograms. That's how sensitive we people are. The races, the pharmacogenomics, if you understand, you will know what kind of, how to use your opioids. We used to give opioid pre-medication when you were there. IM pethidine used to be given. And the moment the patient comes to the OT, if the patient is asleep, we know this is what the patient requires. We don't have to give anything else. But here, everything is given along with anesthesia, and you do not know how much you have given and what was the patient response. You are always blindly giving anesthesia because everything has become so fast track. So what you normally need to do is give a dose of 50 mics, wait and see the response, give another 20 mics. After you have achieved that effect, maybe in the later course of anesthesia, you can again supplement 20 mics more after half an hour, because that's the amount of effect the fentanyl will last, and that's when you need to supplement. But if you have already exhausted your 2 microgram per kg, there is nothing left to be given later on. Everything would be accumulation, and your recovery would not be appropriate. Cooking and anesthesia is all timing. Remember this. If you want to be a very good cook and you want to be a very good anesthetist, you should know that timing. When to time and give a particular drug and how much dose you need to give. Okay? Thank you.